Respected senior members, expert panel, and chairpersons, today my topic is actually a challenging case of low contrast PCI with a masquerading bridge. I'm presenting a case who presented in the ER with a 62-year-old woman presented with acute chest pain. She had diagnosed to have CAD-ACH anstomy with chronic kidney disease with elevated creatinine 2.6 and severe LV dysfunction with RWM with the distal IVS apex anterior wall. Previously had diabetes and dyslipidemia and grade 2 BPH, enrolled CVA in 2012. So on that basis, we had planned an angiogram, and angiogram was showing a triple vessel disease with significant proximal LAD calcification with mid to distal long segment tandem 80 to 90% lesion with a totally occluded LCX obtuse marginal vessel, and RCA was showing an intermediately 70 to 80% distal to precrux area. Angiographically, the mid LAD was not showing any myocardial bridge or any significant lesion. So on that basis, we thought of doing a PCI to LAD with proximal to distal and with the help of HT IVS. Initially, we wired as a marker wire. The run-through wire was parked in diagonal as well as distal LAD, and an IVS study was done. I was showing a significant mixed plaque in the distal LAD and a 360-degree calcium in the proximal LAD with a myocardial bridge in mid LAD. This was each of those segments showing significant lesion. Like for the distal LAD was showing a significant narrowing with mixed plaque at the distal LAD and 360-degree calcium at the proximal LAD and a significant myocardial bridge at the mid LAD measuring a length of 20 mm. You can see that there is a echocardiographic lucent area of the muscle band of a length of 20 millimeters in mid LAD. The proximal area was, MSA was about 3 millimeter square, and distal was about 1.79. There was significant stenosis, and the distal reference myocardial bridge area was 3.78 and 5.78 as well as 9.71. And so there was a significant distortion of myocardial bridge segment that is around 0.53. And there was systolic compression index, which was measured by diastolic minus systolic by diastolic area. And there was in our case, it was 0.23. And there was some amount of fibrous plaque in the mid and the myocardial bridge segment also, but it was not significant. So again, on that basis, we went ahead for angioplasty to the distal LAD as well as proximal LAD. Initially, we proximal LAD pre-dilated with 2.75 into 12 NC balloon, and distal LAD also 2.5 into 12 NC balloon at 12 atmospheres. Following which then we have done a short angiogram, and then further we have extended the distal LAD with the 2.5 into 33 DAS at 12 atmospheres and proximal with 3 into 23, and post-dilated subsequently with the 2.75 into 12 NC balloon at 12 atmospheres in the distal LAD and 3.5 into 8 NC balloon at 16 atmospheres at the proximal LAD. So the final result of and IVS run was also done, and that was showing there was adequate stent opposition and luminal area was good, and we had left of the myocardial bridge segment unstented. And the proximal LAD was measuring about 10.24 and distal was measuring about 5.17. So this was the final IVS results, comparison. So one of the studies that has shown the importance of myocardial bridge and the comparison between the angiogram as well as IVS in left-handed descending artery was from Columbia University, and was showing the determine the incidence, location, and the clinical features of myocardial bridge detected by IVS and compare with the angiographically detectable myocardial bridge. IVUS analyzed about 331 consecutive patients with de novo coronary lesions located in the left-handed descending artery. Angiographically, detected myocardial bridge in only 3% cases, while IVUS detected was about 23%. And out of which 72% of the IVUS detectable myocardial bridge, there was no significant angiographical abnormalities. So from this study, it was showing the systolic milking of the angiographically systolic milking can be seen in myocardial bridge area, and there is an echolucent area in the IVUS. Again, some cases in which there is no significant myocardial bridge, in that cases when we do an IVUS, it was showing that there was a significant echocardial loosened muscle band. So thus, the study showed that the vessel and lumen area in myocardial bridge were significantly smaller than those in adjacent proximal or even distal reference segments. Angiographically detected myocardial bridges are significantly longer and located more proximally in LAD and had more severe systolic compression by IVUS. So angiographically, a silent myocardial bridge more often occurred in presence of an adjacent proximal stenosis and with a reduced ejection fraction. Now, IVUS detectable myocardial bridges were observed in approximately 25% patients undergoing LAD imaging. So my take-home message will be HD IVUS assisted low contrast angioplasty is the best way to revascularize LAD lesions in CKD patients. IVUS is helpful in identifying the angiographically masquerading myocardial bridge. IVUS provides accurate anatomic diagnosis of bridges that are angiographically silent. Stenting should be avoided in significant myocardial bridge segment. Thank you.